Good morning, good afternoon, everyone. My name is Irene Navis. I am the domain manager for the CBRN domain within the Pediatric Pandemic Network. I'm also the Nevada coordinator for RAPM, Western Regional Alliance for Pediatric Emergency Management. I'm helping to co-facilitate today. And very happy to have all of you here in the Disaster Response Collaborative, the focus area of triage, infection control, and decontamination. This is the second in a series of these types of meetings. And so we're very happy that you've been able to join us this morning so that we can start to have this program take shape and for us to hear from you and to be able to get moving on this very exciting project. Next slide, please, Nancy. We have to include some acknowledgments and disclaimers about the Pediatric Pandemic Network being supported by the Health Resources and Services Administration, or HRSA, of the Department of Health and Human Services. We're part of a cooperative agreement. And the content presented here is that of the authors, those of us that put together this program, and doesn't necessarily represent the official views of HRSA, HHS, or the US government. This is a standard disclaimer that we use for all of our programming. Next slide, please. I'm having a hard time seeing because the admit button keeps coming up. Just a financial disclosure, no relevant financial relationships. We have no financial or in-kind commercial support for this project. There's some joint accreditation and credit designation statements there that I won't read to you, but this program is eligible for CE credits. And we'll go into that a little bit more and give you some instruction on how to apply for those credits. So that slide gives you some basic instructions, and you can learn more from the DRC website as well. Next slide, please. Just some announcements. Again, we're very pleased that you've joined us. If you wouldn't mind, please putting your name and your institution in the chat so we can see who was able to join us today. As you could tell, this session is being recorded. The recording and the slides will be posted online on the DRC website, and you'll be notified as soon as those are posted. It does not take very long. If you have questions, please use the Q&A box rather than the chat box so that we can better track those questions. And then again, we have the CE credits there for physicians, nurses, social workers, and EMTs. And we're going to talk about also the benefits of pediatric disaster preparedness and self-assessment for children's hospitals. Next slide, please. We have some introductions that we'll be going through in the agenda. We're going to talk about key takeaways from our first meeting that occurred on November 5th. Some of you may have been present during that meeting as well. We're going to have some case presentations for you, and we're going to break out into some small discussion breakout groups. And we'll have a large group discussion with some polling questions, and then we'll go over next steps with you as well. Thank you for adding your information to the chat. Really appreciate it. The small breakout groups will be facilitated so that you have someone guiding you through the couple questions that we have for you. And the purpose of those is to make sure that we are headed in the right direction in terms of addressing the gaps and the needs that you have as we move through this collaborative. Next slide, please. And I'm just going to go over the objectives really quick today and then turn it over to the next speaker. Our objectives today are to review the priorities for triage, infection control, and decontamination, to hone in further on our discussion topics. We'll be doing that through the polling questions. We're going to identify gaps in planning for TICD. We're going to strengthen emergency operations plans and related annexes. And we're going to prepare for drills and exercises for updated plans. And so we're starting that process today, and each of the sessions will build and build and build until we get to the point where we'll be really deep diving into the programmatic areas that you have most interest in. Next slide, please. Next, I'm going to turn it over to Deneen.
Hi, my name is Doneen.
Take you the rest of the way. Thank you.
Thank you, Irene. Hi, my name is Doneen West, and I'm just really glad that you guys were able to participate in our conversation today. As you know, the Disaster Response Collaborative is based on this checklist created by EMSC, the Emergency Medical Services for Children. And this checklist is really an essential pediatric consideration for every hospital disaster policy. We'll be looking specifically at domains 3, 4, 5, and 6 through this collaborative. You signed up for domain 4, which is triage, infection control, and decontamination, and that will be our focus area. If you notice, there is a link on this slide for you to easily access the actual checklist itself, and we do hope that you'll become familiar with domain 4, which begins on page 11 of that attachment. Next slide, please. Now, I'm just going to briefly introduce you to some of the presenters for this focus area. Irene Navis, who started our conversation today. As she mentioned, she is the CBURN coordinator for both the Pediatric Pandemic Network as well as the Western Regional Alliance for Pediatric Emergency Management, also known as RAPM. And she really comes to us with over 20 years of emergency management experience in various roles. As I said earlier, my name is Doneen West. I am a pharmacist by trade, and I currently help lead the infectious disease domain of the PPN. We also have Nicholas Glom with us today. He is a pediatric emergency medicine physician, and he practices out of UCSF, Benioff, and Oakland. We have Dr. Danielle Zier with us today. She is a pediatric infectious disease physician, and she practices out of Seattle Children's Hospital. Next, we have Dr. Larry Kociolik. He is also a pediatric infectious disease physician, and he practices out of Lurie Children's Hospital in Chicago. Last but not least, we have Dr. Fred Hemmertig, and he is a senior toxicologist at Children's Hospital of Philadelphia. We would also like to get to know you. And so as Irene said earlier, if you're able, please put your name and your organization in the chat if you haven't done so yet. Thank you. Next slide, please. Now you know a little bit about us. So as we get to know you, you can see that we are super excited by our collaborators, and also to look at that we will be working with 13 different hospitals. This map shows you which states the hospitals are from. So 10 different states for 13 hospitals. And if you do see that one Texas has the lines through the state itself in the coloration, it's because there's multiple hospitals from that state. With such diversity, we will be able to speak through a variety of scenarios, share policies and procedures, as well as some best practices. So we're really excited to have you on this call today. Next slide. Just to be a little bit more specific, this slide shows each hospital that we'll be working with. We know that some hospitals had triage, infectious control, and decontamination as a second choice, but we really appreciate you working with us during these sessions. And we're really, like I said, excited to share some policies and procedures. Next slide. Okay, so a little bit more information. So on the top right, you see the type of hospital. So we have 5 of our hospitals will be non-freestanding children's hospitals, and 7 of the hospitals are freestanding children's hospitals. On the bottom left, you can see the size of the hospitals based on the number of licensed pediatric beds. So we do have one hospital that has more than 500 pediatric beds, but the vast majority has between 200 and 499 beds. On the lower right-hand side, you'll also see volumes, and this volume is based off of admission data. So 91% of the hospitals participating have high or greater than 10,000 pediatric admissions annually. Next slide, please. Okay, and lastly, so we know we have 13 hospitals, we're covering 10 states. So what about who the collaborators are? What are their disciplines? So you can see most at 30% are nurses. We have 25% that are physicians, 25% that are other, and then we do have 7% that's unknown. So we'll definitely have to get to learn more about each and every one of you and figure out who that 7% unknown are. Okay, so now that we know a little bit about our collaborators, I am going to turn it over to Dr. Glom, who will be presenting on some of the takeaways from our November session. Dr. Glom.
Thanks, Donine. Good morning, good afternoon, everyone. So just as a reminder, as Donine mentioned, our first session, kind of an introduction section to this focus group was back in November of 2024. If you happen to miss that session, or if you would like access to re-access that session, you can find the slides and recording online. We'll put a link of that meeting in the chat so you can kind of cut and paste that and take a look at that at your leisure. So right now, we just want to really just kind of discuss the different takeaways from the session. And, you know, from an broad overview, you know, as we all know, you know, one of the main reasons why we're here today is that children are more vulnerable in emergencies and disasters. So certainly that was identified as one of the main takeaways. And that children with concern for exposure to either infectious, biological, or chemical agent really require effective and immediate triage to determine the needs for possible isolation, decontamination, or even treatment. And then the triage of infected patients and the prevention or containment of different infectious diseases is also critical to prevent potential exposure of other patients, caregivers, and clinicians. We did identify the need to plan, not just for having specific isolation areas, negative pressure rooms, and appropriate, personal protective equipment, but also making sure that our hospitals provide frequent training so everyone is up to date and they are aware of what they need to do in case of an emergency or disaster. And we also discussed the importance of having a decontamination process specifically for children, including those with special healthcare needs and their families. We can go to the next slide. So during the session, we, as was mentioned, we had two main focus areas. One was triage and decontamination, and then we had infection control. For triage and decontamination portion, we did identify some key elements, including the need to review plans, policies, and procedures related to triage and decontamination of pediatric patients exposed to different CBRN agents, and really identify the gaps and different areas of improvement for our respective hospitals. We identified the need to understand your hospital's role in responding to a chemical or biological incident, especially in caring for children and youth with special healthcare needs, and then consider strategies to elevate your hospital's preparedness capabilities for potential CBRN incidents in the future. So now Dr. Zare is going to review the infection control overview from our November session. You can go to the next slide.
Hi, everyone. We talked about new regulatory updates for infection control related to hospital preparedness for special pathogens, and more specifically, new Joint Commission recommendations around being prepared for special pathogens. We also talked about understanding your hospital's role in caring for patients with special pathogens. Really depends on whether you're a treatment center or an evaluation center, et cetera. And then finally, we talked about specific strategies that can help hospital prepare for special pathogens. Next slide. So we asked the question during this session about whether or not you felt your hospital was ready to care for a pediatric patient with a special pathogen. And what we found was that most people either felt that they could do more to be ready, or they were not ready at all. So I think that just speaks up. For some people, this is work worth embarking on. Next slide. So just to get people thinking a little bit more deeply, we have a case scenario. And this is really, to me, sounds like a very bad case scenario. But what we have here is a sudden outbreak of a novel respiratory virus that has been detected in your community. The virus spreads quickly through airborne particles and has a high transmission rate. Initial cases present with flu-like illness, but it rapidly progresses to severe respiratory distress and multi-organ failure in vulnerable individuals. So in day one is really where this entity is initially detected. A cluster of patients arrive at the emergency department with severe respiratory symptoms, and within hours, the number of patients presenting with similar symptoms increases exponentially. Local health authorities are notified, public health authorities are notified, and initial samples are sent for laboratory testing. Then on day two, we're getting confirmation and escalation. That is, the laboratory results confirm the presence of a novel virus with high transmissibility. And there are now a significant number of healthcare workers who are also showing symptoms. So this is a fast-moving virus for sure. And so then on day three, you are activating your emergency plan. So this is really, again, just to get people thinking about, do you feel somewhat prepared to take action around a situation like this? And we'll have much more opportunity to talk about specifics. So next slide, and I think it's back to you, Nick.
I think
Dr.
maybe
Henry.
Fred. Yeah.
Oh, sorry about that.
No problem. Hi, everyone. As Irene mentioned, and Donine, I'm Fred Henredig. I'm the former medical director of the Poison Center at Children's Hospital in Philadelphia. So this case scenario was developed kind of as a composite of a number of real life incidents that have occurred. I would say it's a little bit of an outlier in terms of the most common kinds of requirements for considering hospital response for a hazardous chemical emergency, but it's still very provocative and thought, should help us think through some of the issues. So this scenario is a local high school reported an incident where a student accidentally spilled a vial of liquid elemental mercury in a classroom. There were about 25 students, one teacher, and one janitor potentially exposed. Several children began to experience breathing problems and complained of headache. And two of the boys who touched the mercury with their hands said that they were developing a rash-like appearance and tingling in their fingers. So some of the things we wanted you to think about were, what would be the immediate response at the school? Who would you think about contacting for medical attention, decontamination issues, and so forth? How about at the hospital, preparing for a potential surge of patients arriving who were victims of this exposure, and thinking through the issues related to triage, potential decontamination needs, medical evaluation. Would some of these kids need to be isolated? And very much, how about communicating with other public health authorities and resources who could advise you about what's going on? And then to think as well about post-incident actions, such as reunification with parents, agency notifications, public information, and so forth. I would say, in my own mind, I'd like you to, with apologies to the old Ghostbusters movie, I think my first challenge for you is when you hear that this happened, who are you going to call? And now I think I turn it back to Danielle. Is that right? Or now we go to the breakout groups if we're having them.
Yeah, so we're gonna do breakout groups where we're all gonna get magically whisked into different rooms. So just to set the scene for the breakout groups, every group will have somebody who was part of the planning process facilitating. But consider the previously discussed scenarios. If one or both of these situations occurred near your hospital, what level of readiness do you believe is present? And then if such situations occurred, what would be your first step? So really just to kind of set the scene, get some level setting for thought process as to first approach. And then we'll get magically whisked. So I think I'm just going to recap, but we'll wait maybe one more second. I think most people are back, right?
Getting there. I think so. I think we're all back.
Okay. So we had some interesting things come up in our group. I'd love to hear from some of the other groups just for a couple minutes of recap. If one of the other facilitators had some interesting conversations, by all means, speak up and let me know what transpired. Maybe on that first scenario, the ID scenario.
This is Danielle. We just talked a lot about more specifics around opportunities to strengthen our processes for the ID one.
Great.
Great. We actually addressed both, and the group kind of compared the two and said they actually felt more prepared for the mercury spill scenario than they did for yet another massive respiratory illness that would really impact systems and supplies and be more prolonged perhaps. And the crowded ED situation, the whether to mask and not mask, and bringing up all of those challenges that folks experienced in COVID, with people having literal PTSD from dealing with COVID. And then if there was another massive scenario to deal with, what the impact would be on the staff, on the C-suite, on the patients, and just taking a look at preparedness maybe from a different angle to make sure people understood the importance of it ongoing, that just because you went through it once with COVID doesn't mean you shouldn't prepare and try and do better with this next round of issues, especially those who are currently dealing with measles and some of the other respiratory things that are coming about, the bird flu and those types of things. It is kind of lending itself to, wait a minute, we have to go back and look at our plans, look at our training. There was the only thing that was brought up in terms of additional training or more frequent training was to do drills and exercises that were CBRN and decontamination focused. Felt like those weren't happening as frequently enough. And one of the issues that was brought up was, again, that fatigue of preparedness, of doing drills, of doing exercises in the midst of real world events that don't seem to be lessening. And then we talked about potentially looking at how these activities can be funded. And so I mentioned that that's something that we will bring up in a future DRC session, is some funding opportunities and funding sources that people can look to as they develop their preparedness activities. Dr. Glom was in our group too. Dr. Glom, did I miss anything critical?
You got it. I think, we also touched on the importance of gaining the support of leadership and C-suite as we go through developing our plans and making sure all of our staff are trained. And tied into what Irene had just mentioned, there's just that conflict sometimes with C-suite and leadership, given they're so customer satisfaction focused, and there are different challenges that we might encounter if we were to have a situation like this infection control scenario where we have to go back to, mandatory masking, et cetera. So given many, many challenges there.
Those are all great points. Yeah, we definitely hit on a number of those as well. We did have an interesting question pop up that I think we're going to be addressing in the future too, as to children with special healthcare needs and the difficulty with isolation, identifying when you have to start isolating. One kid's a little bit weird, 2 kids, okay, now we're seeing something, 3 kids is a trend. When do we start kind of noticing that there's something amiss? Was something that we were kind of bringing up from the ID standpoint. And then Irene, similar, we had the discussion. It's almost easier to deal with decon because you kind of know what you're dealing with to a certain extent. Even if it's something nasty like mercury, you know what you're getting into. So very interesting conversations. Anyone else have any other points that were brought up or questions? If not,
I would just offer that our group would have agreed with all that, I think, and in fact, given that we chose mercury for this particular decontamination scenario, it's important to remember that children who didn't handle the mercury directly and had no skin or clothing contamination in that regard, who were only exposed to mercury vapors and may have breathed them in, that's certainly a health care concern, and they would need to be monitored carefully, but they are not a risk for secondary contamination of other persons or hospital material in any way. So they'd be a lot easier to manage and may not even need hospital referral, as opposed to patients exposed to a highly contagious respiratory pathogen. And in that regard, it's an easier situation to deal with in terms of the patient, but a pretty complicated situation to deal with in terms of the cleanup of the environmental, contamination at the site. But most communities have folks who are specially trained to do that, and you can call them in and they take care of that. That's not usually the healthcare facility's responsibility, unless we spilled the mercury. In the old days, when we had mercury sphygmomanometers, sometimes that would happen in the hospital and create quite a scene. I see a few of the people of my generation nodding their heads about that. I don't think we have to. Now everything's electronic, right? Dynamaps and such.
And Fred, it's funny you say that in our little breakout room. I think it was Julie Cobb for Jefferson County described a very large mercury cleanup that needed to happen involving schools and homes, et cetera. So yeah, it can be a huge load of work.
Absolutely. And I think poison centers I would just put in a plug, are a very good resource for helping, advise in situations like that, from something as little as a broken mercury thermometer or fluorescent light bulb at home to this more, dramatic situation where there's a large spill and a lot of people are exposed.
I think it lends itself to something we can talk about in a future session, is the importance of, it's not just your operations plan in your unit, but it's also your emergency operations plan for your whole hospital. It's your hazmat plan or annex for your whole hospital. It's your ped surge. It's all of those planning pieces that you have to bring together and align. And hopefully by the time we're through with you all, you'll have a good idea on how to do that if you're not doing it already.
Great. I think we're going to move on.
So you can see the poll question. It's pretty basic. What topic are you most interested in learning about? You can see it because I can see your answers. Let's see. Okay, well, that's a little bit of a shocker there. People are more interested in decon than infection control at this moment in time. But then there's a fair amount of people that are interested in both, so thank you for that.
I'm interested in infection control, but I couldn't figure out how to vote. I
Well,
just
thank you
want
for
to go on
saying that,
record as
Fred.
saying that. I'm more scared of that.
Yes. Yes, remember Ebola. Okay. Next slide, please, Nancy. Okay, so here are a couple of infection control gaps, concerns, topical areas, and you'll notice that we're trying to emphasize the identify, isolate, inform approach, which is, if you can remember it, the way to approach this situation when things start happening and everybody gets rattled. So what we want you to do, you can click all of them, but we're just hoping that when I press the poll, you can just choose the top 3 things that you're most concerned about. Sorry, it's not. Oh, I have to go here. Can you see poll number 2? Yes. Okay, good. Thanks, Bridget.
Make sure and scroll down if you aren't seeing it in the poll. Scroll down all the way to the end so you get all the choices.
Yes, it seems like they are not organized from top to bottom. People are still choosing. So what do we see here? Strategies for screening infectious diseases and special pathogens, incident command, multidisciplinary huddles, part of the identify approach, and then a couple of other things are hitting at 6. Who needs to know once you think that there's something going on? And traffic control, which can mean more than one thing. It can be traffic outside the hospital, or more likely, as people are coming in, how do we figure out who needs to be isolated and what's the plan for doing that? I think those are the top 3, but I think it looks like there's interest across the board, unless other people see something different. Okay, Nancy, next slide. This one's a little bit longer. So when you're thinking about biological, chemical, radiological agents, hazards, as well as decontamination, what are your top 3 gaps, concerns, barriers? And yes, Chelsea, thank you for putting your comments in the chat. You should be able to see poll 3, and again, it's longer, so scroll to make sure. 13 choices, looking for your top 3-ish or so. So I'm seeing staff training and availability, which is not surprising. And of course, rapid identification of what agent we are dealing with. And then staff and facility decontamination and PPE decontamination, isolation. And then some 5s, alerts, notifications, and surge and ED decompression. If you think of something else, we're going to talk about that right next. Next slide, please. Okay, so we had a little bit of challenge with poll everywhere, so we can't do the fun word clouds. So look at the top 3 bullet. Are there any additional subtopics in either of the topical areas, infection control, ID versus agents and decontamination? Any additional subtopics that were missed? So think about that. I'm typing the words subtopics missed in the chat to remind you. And then if you think of something, please add it there, and that will help us make sure that we are covering the future topics that you want to learn about or hear about or talk about. I would be surprised if somebody couldn't come up with at least a couple. Johnny, anything coming to mind?
Hard to say, because again, we don't totally know what we're going to be doing. I think the issue of sort of isolation with children with special healthcare needs was something interesting and sort of a good thought exercise for me that I hadn't really considered. And same goes for, you know, that process for decontamination. But that was my thought.
I'm going to put communications in here because I know that whenever anything happens, questions come to the pediatricians in the community, they come into the hospitals, and then in the hospitals and other places, we deal with the people that are worried, also known as the worried well. And do we have handouts or experts or things that are already in print that we can hand out, or does it need to be customized and considered by experts such as yourselves? Thanks to those of you. Oh, sorry.
Yeah, there are many in the chat. Do you want me to read those out loud?
Go ahead. That would help, Nick.
So time frame, coordination with reunification for chemical exposures. Also funding opportunities for developing a decon team, how to recruit and increase participation. isolation as you had typed and children with special healthcare needs. And then age group specific concerns for decontamination, infants specifically. And then for both is situational awareness, how to know when infectious and contamination hazards you need to be concerned about in your community. And let's see, how appropriate for an emergency management meeting. Oh, sorry, that's Larry. Larry has to step off. I'm going too fast reading these. Thanks, Larry, for participating. Familiarity of resources, subject matter expert availability, and decon training, how to do hands-on with the ED in the hospital when the census is high. And then I would also add to that, just repeating what had been mentioned before, and maybe a subset of communications, which you had brought up, Laura, is communications with C-suite and prioritize getting that support on a long-term basis from your specific hospital.
Absolutely. So I think you've already covered this, but I'm just going to ask it anyway. Any specific additional topics that you would like to be addressed in future sessions that haven't been put into the chat or mentioned yet that you can think of? There's a lot that's in here, though.
I think there's some really strategic things that have been mentioned, like the C-suite support and buy-in and education on these issues, and also the financial funding piece of things, seeking supplemental funding to support these activities. And then one thing that came up in our group, and I can't remember if I mentioned it in the brief out, but when you have a system of hospitals and you have to share resources between those hospitals, it's not often that hospitals exercise that piece of deploying teams of folks or making sure hospitals, if they haven't a large number of pediatric patients, that they bring in pediatric resources specific to that system hospital. So I think that might be another strategic thing to work on in future sessions.
Okay, great. Thank you so much for your participation here. Nancy, next slide. So Johnny, from here to the end, it's you or me. What's your preference?
Go for it. You're in a zone.
Okay. I think if you've been to other DRC sessions, you'll already know that we hope you're working within a team, that the team is communicating about your own disaster planning and other response needs as well. Please come to the sessions. The first 6 sessions were great, especially the last 4 where we covered all the topic areas. Everything is recorded and online. Coming soon is the Pediatric Disaster Preparedness Self-Assessment for Children's Hospital, also known as the PDPAC, which is a survey of children's hospitals about preparedness that has never been done before. So that's going to be a real cool thing. And we are going to prioritize asking you and your teams to complete that. And there are some recognition items to folks who complete this lengthy survey, but very, very important because it's going to be done over time. Most of you know that there are virtual tabletop offerings. We're going to talk about that in a second. You can do your own tabletop exercise to evaluate your plan specific to your focus area. And then coming up later on will be a pre and a post drill to look at some actual measures and ways of improvement. We always want the best practices with the best evidence, and any lessons learned through stories or case studies are always critically important. And we hope that you feel like you can speak up and share your ideas and any resources anytime that you like. Next slide. So the tabletop exercises and virtual tabletop exercises are coming up starting next week. You can see the chart in there in the bottom, and it's got by topic. So about 69% of the 112 teams in this collaborative have filled out a survey that have identified their focus area and have signed up for a virtual tabletop exercise that is hosted by our PPN drills and exercises team. So if you're part of a team who hasn't yet signed up, you can email me or the dncppn at austin.utexas.edu email, which I can put in the chat, and we can help you with that. Next slide. A little bit more details on the tabletop exercise planning. You pretty much bring in folks from your hospital, can be external to your team, can be across the hospital, so that you can participate in this virtual tabletop exercise that is hosted and is free and is 3 hours. And then you can work with the people in your hospital and any external guests that are critical to figure out what needs to be improved upon. If you need details, let me know later. Next slide, please. You can see what's coming up next. If you registered for this March session, you were automatically registered to come back on April Fool's Day. It's not a fun topic, but it's an important topic, and we hope you will all join, and that if you have other colleagues on your teams or in other children's hospitals, that you will bring them as well. And then following the cadence of 2 focus group sessions for 2 months, then in May, we'll all come back together and the 4 focus area groups will report out, and we'll talk about how things are going with everybody's tabletop exercises and the collaborative as a whole and what's coming up next. And just a reminder that our time goes to 2:15, which is coming up soon. So next slide, please. Okay, Ready Prep Go is an awesome podcast that you must listen to. Some of the people interviewed are right here with you in this room. This one is particularly good, and this is on the homepage of the PPN website if you need more information. But if you're out running or exercising or walking your dog, you can listen, and they are cool. Next slide, please. This just lets you know that if you are here and one of the things that you want is to get continuing education, that this is the way that you do it. Let's see, I will try to copy that code into the chat while I'm talking with you. Just give me 1 second. And if you need help managing the CE portal or website, we have a very good colleague that helps us out there. Next slide, please. Okay. Thank you for staying until the end. We'd like to hear what you think about this session. There's only 8 questions, and it's required for any CE. I'm so glad you came today. Nick or others, final words?
No, just
thank.
echo. Oh, sorry. Go ahead, Irene.
Oh, I was just going to say thanks, and everything Laura said is spot on. And if you need help in between sessions, please reach out to us, and we'll see you through the next steps. Go ahead, Dr. Glom.
Yeah, just appreciate everybody's participation today and going forward, and really excited to not only share expertise, but also the opportunity for all of us to learn from each other. So thanks, everyone.